Hi.
Good morning.
Can you hear me?
I can hear you great. How you doing?
Good. How are you? Nice to see you again.
Likewise.
It's been a couple of days filled with calls.
It has been. I didn't get the word about yesterday's call.
The evening one?
The facilitator call? I mean, we didn't have it on the scheduled date, and then I've been away from Facebook for a few days, and we didn't get any other notification about it. If Gina hadn't texted me halfway through to say, what do you think about this? I would have known. So.
Oh, no.
I was glad I caught the last half of it, but I'll go back and watch the rest of it today.
Yeah. And then the last night was the June 2019 cohort. Mentoring from Within call, which I think that one was posted.
It was. And I had it on my calendar.
Yeah.
And I just spaced about it.
I listened to that one just for a little bit. Like I was kind of multitasking and but it was good to, I think it's going to be good to be on those, mainly because I enjoyed really listening to Erica, do the teaching, and so I think this is really helpful.
Yeah, I do too.
Nice.
Yeah. Wonder, it's looking like maybe not a lot of people are going to wake up at 9 o'clock.
Yeah, or 6 o'clock.
Or 6 o'clock on the West Coast, yeah. Or who knows what in Romania. Let's see.
Right. Yeah.
Yeah, it's almost dinner time there.
Oh, is it?
Uh-huh.
Yeah. I burnt my hand pretty bad yesterday on bacon grease, so I'm like,
oh no.
All the things that I was supposed to get done in the last 24 hours are not getting done, and I'm feeling a little
yeah. Oh
well.
Did you get medical help?
I mean, I've just been, I really spent most of the day just soaking it in cool water, and then I did get my hands on some aloe.
Oh, good.
And so then I did a bunch of that, and it's feeling remarkably better this morning. I really actually can't believe it. I was not expecting it to feel this much better. So bad, it hurt really, really awfully. So I'm multitasking again.
I see. That's okay.
That happened the first time, but I need my tea.
Yes. Have a spot of tea and give others a few minutes.
Yeah.
Hi, Karen. Karen, we're going to give it a few minutes and see if more people show up. We'll give it a couple of more minutes. If not, we'll have a very cozy call. And that'll be great too.
And it'll be recorded for others, right, later anyway?
That's correct.
Yeah.
Karen, are you on the East Coast too?
West Coast.
Oh my, you are up early.
No, I'm not.
No, this is your norm.
I'm actually not. I am not East Coast, not West Coast. I am Central. I'm in Ontario.
Oh,
I'm
okay.
just half asleep still.
That's okay. I'm grateful you're here.
Looks like we have one other too. Can you see? Is that Inga? Is that how you say it?
Yes, that's me.
Inga?
I don't know if you could see her, Pam, on your screen.
I could, and I mistakenly thought the name was beside. I'm barely awake in the morning. This time of morning too. But I have been up for a bit today. Pardon me. I'm coming off of a bout with bronchitis, so I might be clearing my throat a bit this morning. Bear with me. Let's go ahead and get started. Today is August 22nd, 2019. It's the All Mentor Call on perinatal mood and anxiety disorders. So I know it's not morning, it's morning everywhere for all of us, and For some of you who are listening to the recording, hopefully you're sleeping, getting some good rest. Pardon me. Okay, I won't say pardon me after every time. I want to thank each of you that did whatever it is you had to do to get here today. And those of you who are not on the live call and are watching the recording, I'm grateful to you too for doing that. So thanks. My name is Pam Rowe. I'm a Birthing from Within mentor, doula, and facilitator in training. I took a workshop in May of this year here in Georgia, Atlanta. I live in Atlanta, Georgia, in the U.S. But I took the workshop in Macon, Georgia. It was sponsored by Postpartum Support International and specifically the Georgia group here. It was titled Perinatal Mood Disorders, Components of Care. And it was amazing. It was chock full of information. But it was nothing like a Birthing from Within workshop. We spent 2 days, 9 hours each day, sitting at a table watching more than 800 PowerPoint slides. They did the best they could to make it fun and entertaining, but it was 800 PowerPoint slides. It was not fun. Doesn't sound like fun. Wasn't fun, and it was very informative. We even sat there through meals. We were served meals at the table while the lecture and slides continued. Yeah, it was pretty intense. And still, they worked hard to get everything in that was possible that day. So I have the intention that this will not be as dry as 800 PowerPoint slides. And from here on out, I'm going to call perinatal mood and anxiety disorders by the unfortunate acronym PMADS. Maybe we'll brainstorm for a new one and try to convince the entire medical community to use some other term. What is it that you need to learn today to find this call useful? Or maybe you need to share today. Maybe you know a lot about it already.
I'm actually just, Karen here, I'm actually just realizing that I did the 3-day training in Barrie when they were here this past spring, so I might have to jump off the call. I have a feeling it'll be, although informative, exactly what I did. I also, in fact, did the advanced psychotherapeutic piece as well to this. So I may decide to jump off. Not that I'm sure you have, a different take, but
we'll do
it is a lot. So initially I thought, well, maybe I'll get the Birthing from Within spin on this, but I feel like it might be a bit more.
I'm sorry. Go ahead.
It's okay. I was just drinking coffee. I might, it might just be a bit much to kind of relive that, because as you said, it's a lot.
It's a lot, and I'm not going to cover even, I'm going to cover a teaspoon of that information today. And we will have some Birthing from Within work around it and with it and all of that. But I totally understand, Karen. If you disappear, I'll know why. Are you a professional in the therapy field or
I'm actually shifting gears. So I've been doing birth work for 15 years or so, doulaing and all other, teaching and whatnot.
Right.
But I am shifting gears, going back to school in the fall, actually, for spiritual psychotherapy in order to do a little bit more work, specifically with the same population, but doing more of the therapeutic counseling support piece around this work, because it's just kind of it's evolved into that anyways over the years. Yeah.
And that's wonderful. What a gift you'll be to the people you serve with the knowledge you carry into it about the perinatal year.
Well, thank you. I appreciate that.
Sure.
Yeah, I'm looking forward to that.
Sure. Thanks. So I'll enjoy you being here. however long you feel like you want to be here.
Okay.
That's why I came today too, Pam, is because I feel like I have, with clinical background, a really great grasp of perinatal mood disorders. And but I find in our culture, and I'd love to have this be part of the conversation today, that it's what happens in our general, healthcare system is that we tend to quickly pathologize, if you will. What I think are probably some normal grief and anxiety experiences that moms have after birth, and I think, and before. And I think that in the model that we use in Birthing from Within, there's so many ways that we have the opportunity to give them anticipation about the experiences that they may have with their intense emotional state. Provide, some anticipatory guidance around that and some normalization for it and some ways to cope with it that don't quickly make it into a pathology, I guess,
Yeah.
Here.
Yeah. Yeah. I figured, Karen, that you would have that same perspective. So it's like, in addition to how are we changing birth in our culture as an organization and as a movement in Birthing from Within, I guess one of my questions has been, especially for the past few years, is, how can we change the mindset around, what the intense experiences are that women have emotionally and spiritually in birth, And I too have, I'm familiar with Postpartum Support International. I refer people all the time. I look at the website, and I've had this like major resistance to attending any of the certifications or the workshops, because I know that it's going to be 800 PowerPoint slides. And like, what am I really going to get out of that besides, another certification? Do I really need that? I know it's good information, but I also feel like it's not the perspective that I want to be carrying into the world all the time.
Right. You want to move away from seeing it
as
pathology, or at least define what it is that's normal.
Right.
Normal movement past birth for parents. It includes a lot of intense emotions.
Yeah.
And it's new learning, a new experience, a lot of new experiences. Yeah.
And grief, there's so much grief that comes with becoming a parent, and like just being able to be with that, and not have it be diagnosed as depression so quickly, I think is what's happening. What I'm seeing happening in our community anyways.
And that's interesting because being a lay person, some of the information I got was new to me. Mm-hmm. And I was really excited about it. And I have the perspective that a lot of people deal with disorders or mental illnesses and are ignored in our culture as well. And because we're having this upsurge in awareness for perinatal disorders, and it makes sense to me listening to you and you, Karen, talk that there's going to be that pendulum swing that'll probably go too far in the other direction and start to pathologize normal.
Mm-hmm.
Yeah, interesting. Well,
and the other is true. I mean, it still is hard for moms to get the care that they need, and there's wait lists, and there's not in New Hampshire in particular. Our mental health services are severely underfunded and lacking, and so especially if it's a mom who receives any kind of federal or state insurance. So it is a complex issue for sure.
It is. It's hard to find a balance there. Mm-hmm. Hi, Nancy. Welcome. Inga, do you have anything to add to perspective, to any of those perspectives?
Well, I just have a new baby, as you can see.
Congratulations.
And I live in Norway, so I was quite surprised when I went to, we have like a 6-week checkup with a nurse for the baby. And she handed me, this is new since I had a baby in 2015 as well, and then they didn't do this. Now, obviously, there's more focus on depression and anxiety than it used to be. And she had like this paper with 10 questions and lots of different options for answers that she wanted me to fill out. And luckily I've had the baby before, so I was just like, this is not happening. I'm not using my mental capacity to fill out this questionnaire, so you can score me on whether I have depression or anxiety or disorder of some kind or not. So to me, it seems like that in order to try to address this, at least what I've met here is it's about filling out a form or having like a questionnaire and making sure that you kind of it's very little compassion. It's more like just feeling there's something lacking. It's the wrong way of approaching it that I've been met with here, and it seems my feeling is that because it requires a lot to hold space and to have the conversation about guiding and being together with someone who has some kind of normal or not normal or whatever reaction to getting a baby. We're trying to move away from just being present and having the conversation and being there with them into making it I can't believe I got a questionnaire with 10 questions and I'm 6 weeks postpartum. I mean, my brain doesn't work, so that's just really strange.
Right. And I
so
understand.
That's how I'm coping with it here in Norway. At least
and I don't know if sorry, there's some sort of little delay. It's hard. I apologize for talking over you. I don't know about in Norway, but here it's almost, it is mandated, but there's no enforcement for it by ACOG, the American College of Obstetrics and Gynecology, and the, or council at the end, and the American Association of Pediatricians. It's considered a have-to thing that to talk to every pregnant and postpartum birthing person about this. And I'm getting a whole different perspective than I thought I was going when I was going into this call with, and I suspect I might have to just throw out all my notes and start over, but just kidding. There are some things that I'll go ahead and cover, but it's a very different conversation than I anticipated, and I'm excited about it. Thanks. Anything else?
Yeah, I just wanted to add that I think that maybe Norway is moving a bit more towards how the US is now. We're not quite there, but I can see that we're getting more of this. I think we're moving towards where you are now, which means basically moving a bit away from the compassion and the, I don't know if I have anything to add, but I think we're at a different place, and something is going on here, and I don't think it's right.
Yeah.
And this is the little guy. So
the little guy has a voice this morning.
Yeah, of course, he's very talking.
Yes.
If I log off, it's just because my battery is low, so I'll see the recording later.
All right.
But
thank you. I appreciate you.
Thank you.
And, Nancy, the question was, what do you hope to learn or discuss today to make this call useful? And if you have something to add, I appreciate that. And if not, we'll move on. So I'm going to share some of those things that it sounds like half of you at least already know. I was thinking about what you said, Inga, that it just would be nice if somebody would ask you some questions before they hand you a piece of paper and ask you to fill it out and give your own analysis of where you are. A brief conversation might clarify that for them as well. And that's part of what I think we were talking about earlier, the pendulum swinging too far the other direction. Now that there is more of an awareness about PMADs in this culture and other cultures, that it's becoming more about mental illness which it is technically, by definition, it is mental illness, but a lot of normal behaviors are being lumped into those categories as well. Normal behaviors and feelings and experiences of postpartum and pregnant people. So I'll define PMADS. The word perinatal literally means all around birth. But in the medical community, it's used to to refer to the time from conception until 1 year after birth, or 1 year after an estimated due date in the case of a loss. But a lot of people in the field argue that it should also include the time before pregnancy, because a lot of prospective parents have difficulties with IVF, other methods to become pregnant, or just a difficult time becoming pregnant in general. And so experts assess that number to be about 10% of parents who are looking to become prospective parents, people looking to become pregnant. And that's a large group. So in the conversation today, we're going to include those people in this group as well. We're probably, well, I know, hi Aubrey. We're probably all familiar with the term postpartum depression, and it sounds like everyone in this group so far is. Haven't heard from you, Aubrey, yet, or Nancy, but I make that assumption. There are actually several forms of perinatal mood and anxiety disorders, not just depression. And in the entire perinatal period, that includes depression, anxiety, OCD, and bipolar disorders. But if we limit it to the postpartum period, we can also add in post-traumatic stress disorder and postpartum psychosis. PMADs cross all geographic, socioeconomic, ethnic, and gender lines. It's not just birthing people. It's estimated that 10% of birth partners also deal with PMADs. And that number, most of that research is done only with groups of birth partners. And most of the other research that I'm going to talk about today is done primarily with birthing people. So going forward, unless I say otherwise, we'll assume we're talking about birthing people. So we've already talked about it being a mental illness. And the problem with that is that in our culture and a lot of other cultures, what you were just talking about, Farah and Karen, is that there are so many normal stresses of the perinatal period that in some cases it goes ignored, and in other cases it is diagnosed and treated as a medical issue, even when sometimes it's just normal figuring out how to be parents. The adjustment period for new parents is, as we all know, is very intense. So, but as far as mental illnesses go, if a person's diagnosed with a cold or a flu, there's no stigma attached to that, and they actually get offered help and assistance, advice, support. That's not true with mental illnesses in our culture for the most part. A lot of people are still shamed or ostracized. And consequently, a lot of people who deal with PMADs try to hide those symptoms, and sometimes at dire costs. Give you a brief overview of the history of PMADs. Conversations about them have been happening for at least 2,500 years. Hippocrates, the father of medicine, Hippocrates, is believed to be the first to document them. He speculated that, I'm going to read, that lochia, the bleeding after birth, could be carried toward the head, resulting in agitation, delirium, and attacks of mania. And further, quote, when blood collects at the breasts of women, it indicates madness, end quote. His science was off, obviously. But at least at least he started the conversation, and he created more awareness. We don't know how much there might have been before that, but he certainly increased awareness. And that continued into about the mid 1600s, when there became a lull in the scientific community about, and socially, about PMADs.
Sorry, I guess we can't talk.
You can talk,
Sorry.
please. Jump in.
My bad.
Oh, did you have something to add, Karen?
Yes, but unfortunately I didn't put mute. I was talking to my husband. I'm sorry. I'm gonna mute that.
Oh, okay.
I can listen to you and do double task. Sorry. Bye.
No problem. So that continued until the mid 1600s, when there was a lull in research and a lull in the conversation, and it was that social stigma played a huge part. Women were just considered hysterical after having babies. And then in 1858, Dr. Victor Marseille, he was a French psychologist, wrote a paper on postpartum mental illness. And it wasn't until more than 100 years later, in 1980, that the Marseille Society was formed. But Dr. Marseille's work had greatly increased the conversation. And in 1980, the Marseille Society was formed by Dr. James A. Hamilton. He's considered the modern day father of postpartum psychiatric illnesses. And his work sparked a resurgence in attention to the problem that has continued until now. And lots of other people have jumped in since, of course. Hamilton advocated research and treatment, but he also established a social support movement for PMADs that is still also being used today, and might be the happy medium to have a social support rather than it being either ignored, suppressed, or overtreated. We'll talk about that some more. Anybody have any ideas about that? Okay. Well, then PSI, we've already discussed some on this call. Postpartum Support International is a huge organization that began in 1987. It was started by Jane Honickman in Santa Barbara, California. And their purpose was to increase awareness among public and professional communities both. Jane Honickman was quickly joined by a good many of the leading experts in the field, and they still work with Postpartum Support International, which will henceforth be called PSI. The numbers, part of what PSI does is they have support coordinators in each of the United States, each of the US states, in Canada, Mexico, and more than 40 other countries. They offer helplines, online support groups, trainings like the one that I did, and even more like what you did, Karen. They offer educational DVDs and newsletters, and they even have handouts that you can get that are complimentary, that you can get to share with your students and clients if you like. The other thing that is helpful about PSI's website is they have a membership directory that includes doulas, and they refer to doulas and to birth story listeners, at least one of them. But unfortunately, it doesn't include referrals to Birthing from Within, to our directory to find doulas and professionals. So anyway, I wrote a bit to them last week about that, about changing that, and I haven't heard back yet, but I'll keep you posted. And we certainly, there was a great interest when I did the workshop, because one of the women leading it is a therapist here in Atlanta, and she actually invited me to talk about birth story listening. And there was a lot of interest after that. In that next break, a lot of midwives and therapists, a lot of people came and asked about birth story listening. And so those of you who do that, you might want to pursue being added to the directory and for that as well. a few more stats, and then we'll move on to looking at it a different way. The World Health Organization in 2009 estimated 10% of women dealt with postpartum depression, and they only studied women in their research. It was the National Library of Medicine, which is part of the National Institutes of Health, that updated it in 2018 to 17.7%. But a lot of research indicates that it's more than that. That there is as much as 20 to 25% of people who deal with one or more of these disorders in the perinatal period. You know, it varies a lot from country to country, and it's hard to measure because of people who either aren't aware that they're dealing with a medical issue, or are dealing with it with that stigma and not wanting to be open about it, not feeling comfortable being open about it. So even though it varies from country to country and socioeconomic groups, you know, those are all indicators that we still have a lot of work to do in the field to offer more support when it's actually needed. Baby blues are not included in PMADs because experts say that 80% of birthing people experience mood swings, and the weepiness that goes along with that is part of baby blues during the first 2 to 3 weeks after giving birth. It's a normal adjustment period and resolves without any medical assistance. So we're not going to be talking about baby blues much unless you want to talk about baby blues. So while it might seem counterintuitive, I'm going to begin with the most severe PMAD to talk about today, which is perinatal psychosis. It's extremely rare. 0.1 to 0.2% of birthing people are diagnosed with perinatal psychosis. The onset's really sudden, and it's usually by week 2 after the birth, but very much different than baby blues, of course. What do you know about symptoms of postpartum psychosis? I know some of you know.
Don't want to jump in. So they're very, as you say, they're very rare and they're very extreme. They involve delusions. They involve often voices telling the new parent things that are not healthy for themselves or their child. Will often involve belief structures around what could happen or what will happen to their baby or themselves. So it's a very extreme case of mental illness that can often lead to death, suicide, or infanticide.
Yes, and it does sometimes lead to that, but most of the delusions and the strange beliefs actually are not violent, and that's kind of a misconception in the public knowledge about it. But I know you have a lot deeper knowledge, Karen. Actually, the stats are that people who are diagnosed with postpartum psychosis, 5% commit suicide, and 4%, not 0.4%, 4% involve infanticide. But it's hard to draw the line because that's always a possibility when a person's having delusions that they can turn to being violent in nature. And so, yeah, it's an emergency situation if somebody's doing that. They also have decreased.
And I think.
Go ahead.
I was just going to say, I think often the issue too is that they're not sharing these thoughts and ideas with their loved ones around them. So it's hard to diagnose until it gets to the point of extremity.
Right.
Mm-hmm.
Right. And in this case, they're probably not sharing because they're not aware that it isn't real.
Mm-hmm.
There's a sense that it's real. It's real for them, and so they're rarely capable of having an awareness that what they're dealing with is as dangerous as it is. And one of the other symptoms is that there's a decreased need for sleep or an inability to sleep, and that only complicates it more, as it does all mental illnesses. So the most significant risk factor would be personal or family history of bipolar disorder or a previous psychotic episode. So let's move into that birthing from within place. And instead of just listing, and thank you for sharing those, Karen, instead of listing symptoms and factors, let's paint a picture. What does it look like on a day-to-day basis for a new parent who's given birth and a couple of weeks later is having delusions? What does it look like? How does life altered from that? I'm going to ask those two of you that do know.
I worked with a mom one time who was experiencing postpartum. I mean, a few times, but one in particular, I was seeing her in her home for home visiting, and how it was affecting her was, I mean, it was everything. You know, she couldn't even eat a bowl of cereal without having. It was just like chaos always in her mind. She wasn't able to complete a thought. She had paranoia. She was, you know, just afraid of everything and everyone. So she was very, very defensive. It was like there was no penetrating. It was like someone else had taken over because I knew her, you know, prenatally, and she was a completely different person. You know, it wasn't even the same human. It felt like that I was interacting with, and this was at a time where I really didn't know as much about any of this. So yeah, it affected her ability to function, really, you know, as any disease would affect one's ability to function, you know, diabetes, or, I mean, of course, but it's, you know, the decision-making and everything, but it's like the body is just not able to do what it needs to do. And the mind is not able to guide it, you know?
Right.
In a nutshell.
And did she find,
she was hospitalized, and that was really traumatic because then she was separated from her baby, you know?
Yeah.
But she was hospitalized and,
imagine.
you know, started on some medications and, you know, started on that journey. And okay. And I think that's one of the other challenges in our culture is the lack of, you know, services that can include, you know, some level of integration with the baby, you know, when mom's ready for that. It's often one of the barriers to, I think, moms getting help is that they don't want to be separated from their infants, or they're afraid to be, or they think if they get help that someone's going to take their baby away from them, or if they, you know, that's another big piece is DCYF or Child Protective Services or whatever it is in everyone's state. There certainly have been reports, you know, that we know for sure that if a mom discloses that she's feeling these or having these thoughts, that then, you know, her baby is removed. And that's, you know, those stories are out there. So women are afraid to get the care.
They're warranted fears.
Yeah.
Yeah. Did her family notice first? And
how was her? Yep. Yeah. Her partner. Yep. Her partner did. And it took a bit, you know, to get her the care that she needed because of our healthcare system. But everyone was persistent and did that. But you definitely the partner. And I know that that's a big piece in the research is that partners tend to pick up on it before anybody else does, you know?
Right. Cool. Thank you. Anybody else have anything to add or a different tale? We've all seen too, you know, in the media, people that have not gotten treatment and you know, the ones we hear about are the ones that have included infanticide or suicide and a lot of questions. How did a person get to that point without anybody noticing? And there's actually science that talks about that. that, you know, the family might be dealing with that same stigma and confused and thinking it's just going to pass on its own. There's also science that shows that religious views sometimes factor in because they lend a sense of this is how it's supposed to be in some of the most extreme cases. And so it's very difficult if family doesn't, if family and social associates don't seek help, then it's really difficult to get help for people with psychosis, postpartum psychosis. But even that's temporary and it's treatable with professional help, like the example you shared, Farah. But it is considered an emergency and it's essential to get help immediately. It's the kind of thing that a partner might actually call or carry that person to a facility for inpatient care. Yeah. And it's extremely rare, but it's important to know about it. The other one that is also pretty extreme is post-traumatic stress disorder. Approximately 9% of birthing parents experience postpartum post-traumatic stress disorder, referred to in the future of this call as postpartum PTSD. Now, we all hear about PTSD from military experiences and extreme traumas otherwise, but they're a very real part, 9%, part of postpartum experiences for a lot of birthing parents. What kind of things do you think could create PSTD for a birthing parent? That would be anything that is perceived as traumatic. A prolapsed cord, unplanned cesarean, forceps or vacuums, baby going to the NICU. And sometimes just that transition of feeling powerless, of poor communication, or lack of support during that perinatal period can take those normal feelings of new parenthood into a deeper traumatic experience. The people that are more at risk for that are people who have had experienced previous trauma, like a rape or sexual abuse, or even military experiences or some sort of accident. They're much more likely to experience postpartum PTSD. So let's paint a picture of what this looks like. What are the symptoms of postpartum PTSD? What might they include? Like any other PTSD, they can include flashbacks and nightmares. People avoid the stimuli associated with the event, including thoughts and feelings, even places and people that were there for that time in the birth experience or the pregnancy. There can be an intrusive re-experiencing of the trauma, of the traumatic event. And usually the outward symptoms are persistent increased arousal, either in irritability or difficulty sleeping, hypervigilance with a new baby, exaggerated startle responses, and many of the things that go along with anxiety or panic attacks. And they can feel a sense of unreality and detachment. So what does that look like? Let's paint the picture of what what might look like for a person who's had a baby and is feeling traumatized by the entire birth or a part of the birth, or by a postpartum experience. No? Similarly to what you shared, Farah, about postpartum psychosis, it can be very dramatic as far as the emotional responses to triggers, but it's not as dangerous in the sense that it doesn't include suicide, doesn't often include, even less often than with psychosis, it doesn't include suicide or infanticide, but it can still be a continuation of the trauma for that parent. On a day-to-day basis, what do you think it might be like? What do you picture on a day-to-day basis? If a person's dealing with PTSD, postpartum, it's a lot of the same debilitating things that go along with any of these disorders, but to a pretty significant depth. There might be isolation that parent might be looking to avoid, and might actually be really peppy and perky and happy all the time in an effort to not deal with or look at the perceived trauma. They might be the opposite. They might be really cranky and for no particular reason. And with all of these, but once again, especially with the two more dramatic ones, more severe ones, there's an effect on the entire family. It doesn't just affect the birthing parent. The baby's affected because the birthing parent might be withdrawn and might not be giving the baby the attention that they need. The siblings are affected in much the same way, not being cared for. There might be not legal neglect, but neglect that enough that will affect the child. And partners are affected because often they don't understand what's going on. There's not a lot of conversation in our cultures about PTSD for birthing people. It's often downplayed if there is a conversation about it. So PTSD is temporary as well, and it's treatable. Birth story listening can be helpful for PTSD. It certainly doesn't always require someone getting professional mental health care, but that can be part of it. Farah, as a birth story listener, what might be a line, a red flag that would occur that you'd, or any of the rest of you, if you're birth story listeners as well, that might tell you that, what red flag might tell you that it's time to refer this person to a mental health professional? Anybody who is having extreme pain that doesn't seem to be aided by birth story listening or any other talk, friends, family talking about it with the affected person, or anyone who's having panic attacks or seems to be disoriented. So let's talk about bipolar disorder then. In the perinatal period, bipolar 1 and 2 can appear, either or. And most of the time, it often just looks like severe depression or anxiety. And that's one of the problems, is because it's frequently underdiagnosed. Or you might give me more information, Karen or Farah, or others of you, that tells me that's not the case. But what my research showed was that it is frequently underdiagnosed. I think in the general population that may not be the case, but I'm no professional, so I will stop right there with speaking about that. Risk factors for bipolar mood disorder in the perinatal period, or family or personal histories of bipolar mood disorders. That greatly increases the risk. What do you already know? There's some symptoms that are present in both types of bipolar 1 and bipolar 2. Anybody familiar with symptoms of those? I think we might all need another cup of coffee this morning, although I'm guessing it's not morning for everybody. Okay, I'll share those symptoms. The symptoms that are consistent in bipolar 1 and 2 include racing thoughts, trouble concentrating, little need for sleep, which is different than just a lack of sleep, overconfidence, periods of severely depressed mood and irritability. It can include rapid speech and continuous high energy. Bipolar 1 also adds in that the mood can be better than normal. They can have delusions, they can be impulsive, show poor judgment, have grandiose thoughts. And in bipolar 2, it includes anxiety as well. With a pre-pregnancy history of bipolar disorder, it's always the best practice to consult with a trained professional before pregnancy and have a treatment plan in place in case it's needed. It's not always needed. Any thoughts about bipolar? Let's talk briefly then about OCD, obsessive compulsive disorder. It's often misdiagnosed in perinatal situations. One doesn't have to be diagnosed with OCD, though, to experience those symptoms, and it's often neck and neck with depression. It's present in anxiety. It's actually a part of an anxiety disorder. Let me check notes here. Because research has shown that people with OCD issues are anxious in nature but not delusional, they have a very low risk of acting on any delusions. So it's far more likely that a parent with any of these symptoms takes steps to avoid triggers and recognizes that they're having stress added on by OCD, and they avoid what it might be feared about harm for the babies, or themselves. So the symptoms of OCD include obsessions. We kind of all know about it. Media has given us images of OCD that are skewed sometimes, but mostly real, in that there are obsessions, intrusive thoughts, repetitive thoughts or actions, and specifically in perinatal OCD, it's often related to the baby. Now, the thoughts can be upsetting, and sometimes they need to be treated. But like I said, a lot of parents deal with it on their own. They can have compulsions, a sense of horror about having the obsessions, which is true for all these disorders, that sometimes they're followed by a sense of guilt or denial, and then it just adds another layer to the problem if they don't get help, either on a social level or professional help. Some people with OCD are afraid to be left alone with the baby. And the risk factors, once again, include a family history or personal history of OCD or anxiety. So let's talk about anxiety. Approximately 6% of pregnant people report anxiety, and 10% of postpartum birthing people develop anxiety. Sometimes they experience the anxiety alone, and sometimes it's in combination with depression. In fact, quite often it's in combination with depression. So we may just blend these two conversations. People with anxiety worry a lot. They have fears that things are going to happen, racing thoughts. They might have physical movements, fidgeting, repetitive movements. Dizziness, hot flashes, an inability to sit still. And once again, that disturbance in sleep is an issue. The risks for anxiety disorder include a personal family history of anxiety, previous perinatal depression or anxiety, or a thyroid imbalance. And we haven't really talked about how medical issues can affect some or all of these issues. So let's move on to depression, postpartum or perinatal depression, because we can talk about the two of these and paint that picture together. What do you know about depression? It's the one that most people, most lay people know the most about. Anybody?
I think
I can't hear you.
depression and anxiety are really these, sister experiences often. And it can, obviously, again, make it really hard to parent and take care of a baby because they might just be, if they're depressed, they might be a little more distant and inward and withdrawn. There's a really interesting video clip. I forget where it comes from right now, but it shows, it's, research about the effect of babies. They probably showed it at PSI actually, but it's the research about the effect of, a mom's mental state on the infant's overall well-being and attachment to her and everything. And where the mom, just doesn't have a response. So she's not really interacting. She doesn't have those facial, changes and responses and the tone of her voice and all those things that moms usually, are able to do when they're well. And the baby gets very stressed by mom's very flat, unchanged affect.
Yeah.
And so it can really, affect that relationship. And she's just not able to have have it in her to engage when she's really depressed, and she might be going through the motions. She might still be able to actually be very capable of feeding her baby and getting her baby to bed and keeping her baby safe even. But she's not building necessarily a relationship with her baby. She's just sort of doing what needs to be done. And that doesn't feel good to her. It feels a lot of times they carry a lot of guilt around that.
Guilt's a big part of it. And this is supposed to be the happiest time in my life and everything's supposed to be blissful, and what's wrong with me that I don't feel those things. A crying mother can't really have that lilting voice we all use when we talk to babies, or we often use. I won't say everyone does. And risk factors are the same, that if a person has a history of depression, they're much more likely to deal with it in the perinatal period. And that's even doubled if they have a history of perinatal depression, even if it was just limited to that. And I like that in the risk factors for depression and anxiety, they include things like inadequate support for caring for the baby, financial stress, marital stress, premenstrual dysphoric disorder, which is PMDD, or often PMS. Complications in pregnancy or the birth or breastfeeding can accentuate or create depression and anxiety symptoms. A major recent life event can be a risk factor. A house move, a job loss, the loss of a loved one. Parents of multiples are more likely to deal with it. Parents whose infants have spent time in the NICU, in neonatal intensive care. Parents who've gone through infertility treatments. loss of an old identity is even included. And that really speaks to what you were talking about earlier, Farah, and you, Karen, that, you know, how do we draw that line between what's normal and what's a mental illness? And, you know, every birthing parent experiences loss of an old identity. They've moved into a new role in their lives, even if it's a subsequent birth, even if it isn't a primary birth, because they've never been a parent of two children or 3 children or 5 children or however many it is. And physically, any form of diabetes, 1, 2, or gestational, increases the odds of depression and anxiety in the perinatal period. So it's temporary, like all the rest, and can be helped. It's treatable with professional help, and once again, can be helped socially as well, depending on the severity. We'll talk just briefly about the screening, and then I want to just talk in general but let's talk briefly about screening. It's always based on a risk-benefit analysis. Some medications are used sometimes, and those benefits and risks are weighed, and it's made on a case-by-case basis always. Mandatory screening in pregnancy, and we already shared that it's recommended or mandated by PSI, ACOG, AAP, and a lot of other organizations. And I suspect the one that Inga was talking about with the 10 questions was the Edinburgh postnatal depression scale. And I, after working with a therapist here just on recognizing these issues, it was suggested, and I do give these in my classes. I give the front page of that Edinburgh scale, just so parents can, should they be concerned that they're depressed or anxious or any of the other illnesses, can answer the questions and find either comfort that they're not being, that they don't answer of them all positively, or they might be moved to find help, or at least to talk about the situation with family members and friends. So with what we know about these, how does it affect our work in birthing from within? How does it fit into our work? Just to have an awareness and a knowledge of perinatal mood and anxiety disorders.
I think it's an important point what you just brought up, Pam, is that you share some of this information in your class prenatally, because one thing that we do know, and research actually points to this, is that the best time to learn about it and for parents to know what to watch for and know the resources is prenatally, not those 3 days postpartum, which is oftentimes in our culture when they're kind of hearing about it for the first time, is when the nurse goes in and has her little checky checklist and says, you need to know this and you need to do this and go home with this and go home with this. Like later, she's not going to have remembered any of that. She has no idea. One of the nurses that I work with did a research study on the effect of teaching moms about postpartum mood disorders in the first 2 days postpartum, and their retention of that information at like a couple intervals, like 3 weeks and 6 weeks postpartum or something. And the findings were that essentially she didn't remember any of it. She didn't even know the conversation, right? Because her brain isn't in a place to do that. So we know that in this world, and birthing from within, it's like, of course, she's integrating all these other really important things. She's not going to remember, signs and symptoms of that or whatever. Right. So I think what we can do in our work is to have it be part of like that, like the postpartum plan that we use, that exercise or whatever, something that we talk a little bit about it, bring up what they already, help them to identify what they already know, what they might be worried about, just like we do with other processes, and, make sure that they do have some resources, and really weave it into the change in who they are, as a person is going to happen. And that may come with some feelings of anxiousness, and that may come with some feelings of sadness, and to give them some anticipation around that. So when they are feeling anxious or sad in postpartum, they're not automatically thinking like, oh my gosh, something's wrong with me. This must be a pathology.
Right. Yeah. Right. Even you said earlier, even grief is a normal part of that time period.
Right.
Yeah.
Yeah. And so how to just plant those seeds through storytelling or metaphor or whatever it is that we're doing, so that then when it does happen, they're like, oh, that's right. I remember this story versus I remember a checklist from 24 hours after I gave birth, you know? So.
I don't even know where that is anymore.
Right.
That thing they send home with every mother, every parent. So I think it's important too to really emphasize it with partners, with birth partners, because frequently they're the first to see symptoms, first to notice them as symptoms of depression, anxiety, or any of the others, and can deal with it socially or deal with it medically, whatever's required in each case. Once again, case by case basis. So, does anybody have any questions? We've already talked a bit about, sorry, I asked a question. Anybody have any questions? No? We've talked a bit about when it's appropriate to refer a client for professional help. It might be something that you've heard or something that you've observed, not just as a birth story listener, but in any of our roles within Birthing from Within. I think following what Vera just said, it can be about, especially after, if we're sharing those things with parents prenatally, those handouts, information, metaphors, birth stories that share with them about what is normal after a baby comes, then the things that we can look for are signs of severe issues. Detachment, delusions are in the most extreme cases, but also a detachment to the degree that the birthing parents feel dysfunctional in the relationship and the new household environment. And they may not express as I'm so sad, I cry all the time. They may just say, I can't seem to get with it. I just, like you said, Farah, and I've heard so many times, I'm just going through the motions. I feel numb. Those are big red flags for supporting people in finding help. We do good work, and we're well past our time limit already. Is there anything else we need to talk about? I put a list of resources in the chat section. I hope you can copy and paste them if you want them, but I'll also include them in the comments when this recorded is posted on Facebook. So feel free to add to them. And I thank you all for your input and interest, and it's been a fun call. Appreciate it. Thanks for letting me share. Sure, you're welcome. Have a great one.
You too.
Bye.
Bye.